Good evening, everyone. It's my pleasure to welcome you to this, the fourth in a series of public talks on optimal aging, different aspects of optimal aging. My name is Susan Denberg. I'm Associate Vice President in the Faculty of Health Sciences at McMaster University. And it's been my honor and pleasure to shepherd a very generous gift from our Chancellor, Suzanne Labarge, to create the McMaster Optimal Aging Initiative. And this series of talks is part of that. And we're delighted that you've come. And I think I recognize a couple of faces from the last show, so that's terrific. I'd like to take the opportunity to welcome our keynote speaker, Dr. Graham Ellis, who will describe why care provided in the home can trump care in hospitals, a topic that's of great interest. And there's just today been a pronouncement by the Canadian Nursing Association that talks about healthy aging starting in the home. So this is a very timely topic. I want to give special thanks to the McMaster Health Forum for hosting these events. And I want to also tell you that McMaster's expertise in aging continues to grow. We want to consider ourselves as the gateway to optimal aging with such initiatives as the Canadian Longitudinal Studies on Aging, the Labarge Initiative, the Gilbray Centre. These are all converging to answer important questions around aging. We hope that the dialogue that's initiated tonight will continue in your homes and in the university, amongst yourselves and your communities, and we hope you enjoy the evening. I'll turn over to Ilana Churia, Managing Director of the McMaster Health Forum, who will introduce the speaker.
Thank you very much, Susan. Just a few housekeeping notes, everyone. So welcome to those here, and welcome to those who are joining us online. Last time we had about 130 people online, so I know the crowd is growing there. There will be an opportunity for questions and answers in the second half of our event. There is a microphone right here in the middle. So for those in person, we'd invite you to come to the mic and ask your questions. And for those online, you have an opportunity to submit your questions and your comments by Twitter, using MacAging hashtag. For those in the room, if you have your mobile phones with you, if you could please just turn them on silent mode for the duration of the event. And I also need to mention that we'll be taking photos throughout the event, and we're also recording this so that people who couldn't join us tonight here or online can watch it later on our YouTube channel. Just a few words before we begin about the context for those events. Susan mentioned this is the fourth in a series that the McMaster Health Forum has organized this fall on a range of topics related to optimal aging. If you'd like a listing of the roster of events and their topics, they're available in a handout at the desk there behind you. So on your way out, you can pick up one. Or you can access the full listing on the forum website, mcmasterhealthforum.org. Recordings from previous talks are already available on our YouTube channel. And with respect to upcoming talks, I'll tell you a bit about two of them at the end of our event tonight. So one other thing, our topic tonight builds on a citizen panel that we convened in August on the topic of meeting the future home and community care needs of older adults in Ontario. The outputs from that panel, a topic overview, a citizen brief summarizing the key messages from research evidence, written in consumer-friendly language, as well as a summary of the panel deliberations and the key themes that emerged from it, are available on the McMaster Forum's website, Health Forum's website. And in organizing tonight's event, we worked with our colleagues from the Ontario Association of Community Care Access Centre, whose recent initiative called Health Comes Home was designed to spark a broad dialogue about the future of home and community care. So now to the agenda. We are extremely privileged to have with us tonight Dr. Graham Ellis, a geriatrician from Scotland who's leading a novel hospital-at-home service that is achieving very high levels of satisfaction among patients. Dr. Ellis is Associate Medical Director of the Older People's Clinical Forum in Lanarkshire, Scotland, and a Senior Clinical Lecturer with the University of Glasgow. The Hospital at Home service has been operating for 3 years and has been successful in having more patients be cared for at home rather than in the hospital, with services provided by a team of nurses, doctors, social care staff, and other health providers. It has allowed for significant service redesign and has changed attitude and perceptions to hospital admissions. And tonight, Dr. Ellis will explain how the service works and why it has been rated so highly by patients. And Dr. Ellis is currently working on, with other researchers across the United Kingdom, on the largest randomized controlled trial of hospital at home ever attempted. And I'm sure he'll tell us about it tonight. So we're absolutely thrilled to have him with us tonight. We're also joined by Andrew Costa, Assistant Professor in the Department of Clinical Epidemiology and Biostatistics at the Faculty of Health Sciences, and Research Lead in the Michael de Groot School of Medicine at McMaster University. His work focuses on identifying people at risk for poor outcomes and unplanned use of health services. He developed a decision support tool to predict unplanned emergency department use among home care patients, clients. And Andrew will provide his comments after hearing Graham's talk. Welcome both. I will now invite Graham Ellis to the podium.
Okay, well, thank you very much, and thank you for the invitation to come and speak. It's a real privilege for me to come here. This is my first trip to Canada, and I have to say I'm so impressed so far. I have had a few complaints that I don't sound enough like Shrek, despite coming from Scotland. But you may have noticed I have other similarities in terms of facial features, so I hope that makes up for it. I could speak like him, but I might have to charge more. I work in Scotland, and highlighted in dark blue is the Health Board of Lanarkshire, which I like to think of as the rough diamond at the heart of Scotland. And just if it helps to orientate you, this part here is Glasgow, and here is Edinburgh, and we're sandwiched between the two. You may well have seen the film Braveheart, so that famous battle was fought about there. But I thought you might find it more interesting to know that round about there is a small town called Hamilton, which is your hometown's hometown, I think. Now, I'm a doctor in geriatrics. I'm also a manager within the Health Board, and I do research in older people's care services, and it's really the combination of those that I want to try and bring to you today and talk through. I want to move from the evidence and what it says about potential models of care into how we have had to implement them, and back into the evidence, trying to complete that circle. And I know that McMaster is very keen on uniting policy with the public and with research evidence, so I'm trying to do the best to do that. Now, in terms of the demographic of Canada, it's a very similar picture to the demographic of the UK, and in fact many developed countries. This graph comes from your own country, and this is the profile in the terms of the proportion of the older population, i.e. those over 65 in the coming decades. This is a success story. This is a success story of health and socioeconomic development, but it does pose some huge challenges. This is the Scottish profile of how things will look in 2031. I will not be as close to retirement then as I had hoped, but the graph really is illustrating blue for men on the left, and I'm not sure what that colour is for the women on the right. But the age bands of the population will be very similar to yours in Canada. And it's predicted by 2031 that, I'm trying to remember, 1 in 4 people will be over the age of 65. Now, in terms of our health systems, many people in government and in healthcare are looking at that shape and thinking they've maybe seen it somewhere before. And they're concerned that a system that is full of older people with the current level of needs could be a concern. Just to illustrate, this graph's slightly out of date, but because it shows Scotland and Lanarkshire, I wanted to show what's happening with admissions to hospital. Scotland in blue, the rate of admissions to hospital for the over 75s increases at about 2 to 3% per year. In Lanarkshire, we like to think we're doing better than that. We seem to be increasing at a rate of 5% per year. So these are statistics that are not sustainable longer term. And in fact, someone at Scottish Government looked at the implications of that aging profile if we were to change nothing else. Based on figures in 2007, they've projected the number of hospital beds that we think we would need in order to meet the needs of those people. And what they projected was that we would need to build a new hospital every 3 years if we change nothing else in the way in which we deliver care for the older population. In England, meanwhile, in the Royal College of Physicians, in 2012, they delivered a report, and subsequent to the report, commissioned a paper on redesigning secondary health care, hospital care, to deal with the crisis, because we essentially have an unsustainable future in terms of our hospital systems. And some of the key themes that they brought out of the report are that 2/3 of patients admitted to hospital are older adults. Not only that, but the rate at which the increase in admissions has happened has favored, if that's the right word, an increase in older adult admissions to hospital, such that 1 in 4 hospital beds is now occupied by someone over the age of 85. Now, as a geriatrician, there's a fine line to be trodden between being concerned about the hospital systems and being concerned for the needs of older people to access appropriate care. But I noticed from your own newspapers, I'm not sure what are the best newspapers to read in Canada, I did a little bit of searching, but there's a similar language being used around the future, the demographic, and how it might impact on acute care in much of your online newspapers, certainly. Talks of a grey tsunami are potentially slightly politically fraught language, but it's recognized that aging in the population has impacts for the whole healthcare system. If I can run back to the economic situation in the UK, I'm delighted that yours is different to ours. However, as a publicly funded healthcare system, the impact of the financial crisis is fairly significant for us. And this graph was released last year, I believe, in terms of trying to predict how changes to the funding in the healthcare system to deal with the economic crisis would impact on healthcare, and significantly how long it would take us to recover to previous levels of public funding. So as a public servant, this is rather depressing kind of figures, and it raises really challenging questions about how we're going to provide healthcare for this aging demographic. Now, I sometimes use the bath analogy for some of our managers. I'm hoping they don't watch this online, but I like to think of hospitals as a similar kind of parallel to a bath. The taps are jammed on, and we've said that the increase in admissions is roughly a 5% per year increase. So the taps are flowing fuller than ever before. There are sometimes challenges with the bath plug, sometimes it's not. There are problems with drainage, you might say. And so we have a challenge. What do we do about that? And as far as I can see, we've only really got 3 options. We either attempt to turn off the taps. We either attempt to address the admissions to hospital at source and reduce admissions, or we look at the bath plug and we look at whether we can create an additional bath plug. Can we increase the flow out of hospital? And both of those might be the right thing to do. But what it looks like we are not going to be able to do is continue to build bigger baths or more hospitals. Every year, winter takes the British government by surprise, and every year our funding for, this is terrible, this is going online, but every year our funding for healthcare in winter receives short-term pump-primed funding, as though winter was just something that came off as a one-off. And generally, the emphasis has often been on increasing the size of the bath, opening winter wards, creating capacity within the system. But it would be my feeling that that is no longer a sustainable option for us to do. We need to think more smart around the flow into and out of hospitals. And that also gives us opportunities. I think we also need to look at the experience from the patient's point of view. Just out of interest, anyone like to guess how old this lady is at the time of the photograph? Anyone like to make an offer, a first bid? 92? Do I get any more higher than 92? No, you're a cautious audience. Anyone like to advance on 92? 84, we're going down the way. Any other offers? 98? Do I hear anything more than 98? 105, did you say? Anyone like to attempt higher than that? 110, sold to the lady in pink. She's 109 when this photograph was taken. She was born a few months after Queen Victoria died, and so she'd seen an incredible history through the 20th century. She's quite a feisty woman. Do you use that word over here? Okay. Thrawn, you don't use that one. That's the Scottish one. Thrawn? No, okay. That's a Scottish word for stubborn and determined. Anyone who reaches that age is fairly determined. She was still the matriarch in the house. She ruled the roost very much. But a fascinating lady. Anyway, she's just here for illustration that we need to look at it from the patient's perspective. And one of the things that has been a challenge in the UK is several high-profile revelations around the quality of care that we deliver to patients that have questioned our attitudes and our care at the centre of healthcare. You may not have heard of these, and that may be a good thing, but there was a recent fairly high-profile failing in a hospital in England that started to bring into question the way in which we deliver healthcare. This hit our national news and has dealt a big blow to some of our thinking around healthcare. And interestingly, the challenges here were a culture and a process that was focused on targets and focused on throughput, but had lost sight of patient experience and patient care. And it came to light when a higher than acceptable level of deaths were noted. And in exploring this, in the inquiry, it was found that there were a large number of, unfortunately, inappropriate, I'm having to choose my language carefully, there were people who should not have died in the system. But concerningly, it wasn't just around that one fact, it was around a whole system that had lost sight of what it was there for. It had lost the care element. So under pressure, we've started to think again about what is it healthcare is here for, who is healthcare here for, and how can we put that front and center in terms of what we do. So I want to try and argue for hospital at home, and I'm using some statistics gleaned from different elements of research that are reasons, if you like, that we should start thinking differently about hospitals. Not necessarily to question their safety, but to look at them and say, well, is this the right way to continue? For instance, it's recognized that in hospital we have particular bugs, bacteria, infections that you can acquire in hospital in a different way than you can acquire in the community. In the UK, that figure is quoted at 5%. I believe in Australia it's quoted at near 10%. And the public are exercised by this risk from being in hospital. Delirium, you may well know, is an acute confusional state that has a significant health impact, either in terms of long-term confusion or in terms of function, and in fact it has an associated mortality and morbidity with it that is concerning. And it isn't always the case that delirium is caused by illness. It sometimes seems to be as a consequence of translocation, of moving into a different health setting. We recognize that following admission to hospital, a proportion of patients will acquire delirium. How much of that is due to the illness and how much of that is due to the different setting is hard to tell. The literature says that the range could be anything between 3 and 30%. And that's a fairly broad range. Most studies quote somewhere in the middle. This is a significant health impact, partly, perhaps, potentially impacted on by admission to hospital itself. We know from literature and from experience that errors in the transcription, errors in the giving and the taking of drugs are significant, particularly where the health context changes. And in that handover between, say, primary care and secondary care, the risk of errors, the risk of transcribing errors, the risk of getting it wrong are significant. There was an interesting paper, an American paper, that looked at acquired immobility. You expect when you go into hospital and you need rehabilitation that your immobility, if it's a challenge, is better from rehabilitation in hospital. But there is some evidence that being in a hospital setting may not be associated with an improvement necessarily. So in other words, some people following admission to hospital may become less mobile, more dependent. And that's a challenging thing to consider. Rates of admission to nursing home care are variable depending on your health context, which part of the world you're in. 40% I would have thought was very high, but it is significant. The concern is if we admit you to hospital, we sit you by a bed, we bring food to you, to what extent do you become institutionalized by the systems we've created? And also, although being in hospital might relieve strain from a carer, it's recognized in the literature that it actually creates strain for family and carers too. Coming up to the hospital, finding out about the loved one and the patient, these are all significant strains for family. So that, if you like, presents some of the challenges and some of the reasons why hospital at home might be something we would consider. But there is also an evidence base that I'd like to sort of try and walk you through for hospital at home. Hospital at home has a specific definition. It is a service by healthcare professionals for a condition that would otherwise require the patient to stay or be admitted to hospital and delivered in the patient's own home. So in other words, it's about hospital replacement. And the research I'm going to go into in a bit more detail is led by a Cochrane review, which is a synthesis of some of the best evidence on the subject. But just for clarification, because I think I find this is confusing in the UK, where the language shouldn't be confusing, but it is a complex area. Hospital at home is not about enhancing community rehabilitation necessarily. It's not about enhancing primary care. And it's not about chronic disease management. It's specifically about a hospital replacement service. And if I can get you to stick with that definition, I can expand on it a little bit. Now, the trials that have been done in a number of different conditions. I'm interested particularly in trials of medicine for older adults with a number of conditions. But there have been trials in respiratory conditions, trials in infective conditions such as cellulitis, trials particularly in dementia, and a number of trials in stroke. So these groups of conditions, these groups of patients, form the broader range of research trials that have been done on hospital at home. Now, since the first synthesis, the first Cochrane review or collaborative review of these trials was started in 1997, there's been a kind of expansion of the number of trials that are available. Now, this is great. This is exactly what we want. We need more evidence. We need a breadth of evidence. But as the last review conducted in 2009 demonstrated, in fact, there are now a range of diverse descriptions of what hospital at home means. So to walk you through that, the gold bar, if you like, stands for the kind of trials where patients are getting early discharge hospital at home. In other words, they are more medically stable, less acute, but the ongoing rehabilitation needs are met not in a hospital building, but back in the patient's home. So that element of hospital care, post-acute, is done in the hospital, in the patient's home. The green trials are a small but a growing group of trials looking at end-of-life care in the patient's own home. Can we provide palliative and supportive care at the end of a person's life? And the blue bar, which I'm going to concentrate more on for this talk, is at the front end of hospital. When someone's acutely ill, can you replace that acute element of hospital in the person's own home? Now, the review looked at a number of different outcomes, and this isn't all of them, but some of the key ones certainly. Mortality would be fairly important to understand, as it's safe to do this in someone's house. Transfer to hospital or readmission, if someone is eventually readmitted to hospital, we're just delaying the inevitable. And patients want to live at home. They don't want to end up in an institution, whether that's a care home or a hospital. And there are other outcomes that are important. The satisfaction of the patient is important, as well as the care, the family, perhaps even the primary care providers, and also costs are important too. So all these were outcomes in the review. Now there were 10 trials included in the blue bar, if you remember, the front end of hospital, the admission avoidance hospital at home, recruiting just over 1,300 patients, so not a large number of trials. The majority of these took patients from the emergency department and stood them down into hospital at home ward, but some of them referred direct from the primary care physician to the hospital at home teams. Now, just to walk through some of the key outcomes, the first and perhaps the most important to highlight is the outcome of mortality at 6 months. And this was the longest period of follow-up for most of the trials. And what's really striking about this result is that the mortality for this summary of all these trials was lower in those trials where patients were treated at home, or rather it was lower in the group where patients were treated at home. If you're not familiar with this type of plot, which is known as the forest plot, and it doesn't come out very clear on the graph, each individual line is a trial with the trialist's name and the year that the trial was conducted. And you can see what is normally a small box with whiskers, as they call it. That is the evidence from that individual trial. But at the bottom of that is a small diamond, which is the overall result of synthesizing those trials together. Now, it doesn't project very well, but what it shows is roughly a 24% reduction in the risk of death at 6 months for patients who are treated in their own home. So a significant reduction in mortality at 6 months. One of the other really important messages coming out from this was the odds of ending up in a care home setting were also significantly reduced for a number of the trials. So it seemed to keep patients in the community for longer. And that's an important message. Satisfaction, perhaps not surprisingly, was significantly increased for patients, but also for carers. The trial from the primary care clinicians was neutral, but the patient message was significant and strong, that patients preferred being treated in their own home. The costs appeared to be reduced. It's quite complex trying to understand all the costs, and it was difficult to synthesize all of that into one overall result. But it appeared to be reduced. But the time spent in hospital was definitely reduced quite significantly. And the impact on the wider family may have been better. To try and quantify some of those outcomes, I want to look at just two. Readmission was a different story. The risk of being readmitted to hospital was ever so slightly higher. It wasn't significant in statistical terms, but was slightly higher. So that may be significant. But to put that in context, for every 200 patients treated by hospital at home, one patient might end up being readmitted to hospital where they might not have in traditional models of care. So that's not a significantly large impact in terms of the size of it. In contrast, however, you'd only need to treat about 18 patients for one more patient to be alive at 6 months with hospital at home. Does that make sense? I've not explained that very well. So in other words, there's a slight trend to some people being admitted to hospital, but it's a small trend. There is a significant benefit in terms of the number who are alive at 6 months, and you only maybe need to treat 18 people before, statistically, one more person's alive in their own home. Now, there are some challenges with this research evidence base, but I'm going to come back to them because I want to address why we want to look at this in more research up and coming. What I'd like to do is introduce you to my own team and our own hospital home team. I realized I should have had their photographs up here, and they'll probably kill me if they ever see this. However, I have cartoons for the moment. We're a small team, and we're dealing with a population of around about 160,000. I should have explained from the outset, the population of our health board area is the same size as your population for Hamilton, so it's comparable. We have 3 acute hospitals, and this was set up as a pilot in one sector surrounding one hospital, so a population of 160,000. Small team with one whole-time equivalent geriatrician, though we work that as a team. And we have a core team of therapists and nurses who have advanced training, so a little bit like physician's assistants, to do the medical assessments that a junior doctor might do and to do a lot of the workup. We mimic hospital systems. We have hospital paperwork. We do prescribing on a GP prescribing pad. And we've negotiated, with great difficulty, we've negotiated access to emergency diagnostics the same speed as though the patient were in the emergency department or in the hospital, and that was crucial. We do our daily ward rounds. They have to be a bit virtual because we can't bring all the patients to us. And we have specific admission criteria. So we're targeting over 75s, though we've not refused anyone on the basis of age. We'll only refuse cardiac problems, such as chest pain, stroke, and someone in need of clear need of surgery. So these are the only exclusion criteria. Now, I don't want you to read this graph, this picture, because it's too small to project, but the point of it is really to illustrate that we are working within a broad context in the community of a wide range of services. And we're quite clear that we fit into a wider team, whether that's primary care, medical services, primary care nursing, social work teams, and charity organizations there to support patients. So there is a wide network of support already there, and we're only one piece in that jigsaw. And that may be important to understand the context in which we're working. But I wondered if I could talk through a case and try and illustrate how a case might present us. If I take the story of a man fairly early in our team's start, we had this man present to us, an 81-year-old man who lives with his elderly wife, and he lives upstairs in the bedroom. Sorry, the bedroom is upstairs. He lives in a 2-story house. That is relevant later on, but he had multiple health problems, including congestive cardiac failure, and he presented on the morning in question with breathlessness. Now, I want to walk through what would be a typical experience for this man if he came to our hospital system. His wife phoned first thing in the morning. She didn't want to bother the doctor before 9 o'clock, but she was worried about him. He couldn't walk more than 6 feet. He was very breathless and quite unwell. In the normal course of events, the GP might come out and visit the patient and organize an ambulance. The ambulance would have a normal response time of 2 to 4 hours for what we would call a non-blue light emergency. And the patient would arrive at the emergency department perhaps around 11, 12 o'clock, middays when people start to pitch up. They normally would be seen by a junior doctor who would do the initial assessment, cardiograph, order bloods and tests, and then would be subsequently admitted to what we call a medical receiving unit or a medical admissions unit. They would be seen by a second junior doctor here who would add to that history and add to that examination and to the tests. And then subsequently we would be seen by a consultant like myself. And at this stage, we're talking late in the afternoon or possibly 5 o'clock. The consultant would do an overview of the patient's history, their examination, their results to date, and decide on treatments. Now, if they were forward-thinking, they might think about alternatives to admission with our early supported discharge team. But if they're not, the patient would be admitted to a downstream ward. However, there would be significant challenges for this patient having pitched up in hospital to getting home. The physiotherapist would point out that they can still only walk 6 feet. They can't manage stairs. The occupational therapist would point out that the patient needs aids and adaptations, perhaps home care such as home help. The doctors would need to stabilize the medications to manage the patient's atrial fibrillation and their heart failure. And the patient would, of course, need transport home. So logistically, this patient is going to find it very hard to get home from hospital and might well stay for what would be our average length of stay, perhaps 10 days, perhaps not, in hospital care. That would be the traditional route for a patient presenting in this way. However, in our case, in this patient's case, the story was slightly different. Same symptoms, the patient called the doctor, and the doctor came out to review the patient at home. He couldn't walk more than 6 feet, was breathless, quite unwell. In this case, the call was diverted to our hospital at home team rather than the hospital, and we sent a practitioner out to see the patient in their house. We've promised that they will appear within the house within the hour, and that's a commitment that we've made. They arrive and do what that junior doctor would have done in the emergency department. That is the physical examination, the story, the cardiograph, the blood tests, and so on. And then the consultant would appear, that might be me, and arrive usually within 1 to 2 hours to review the patient and to do the same examination history taking as would have been done in the medical assessment unit, but this time in the patient's living room or bedroom in this case. So we would make the same decision around their management plan, prescribe the medications, the same medications they would get in hospital, and all the relevant other services that we require for this particular patient would be organized in the house. So he required a commode because he couldn't manage to the bathroom for safety reasons. He required home care to help him washing and dressing while he was unwell. Once he started to get better and we started to get him physically feeling more able to breathe, he was then more able to mobilize, and we worked with him with a physiotherapist to do stairs practice. And by the end of 5 days, he was independent and back at his previous level of fitness, and we were able to discharge him back to his primary care team, as well as he would have been if he had returned from hospital. So that's an example of where the multidisciplinary team in the patient's house makes a very different outcome, a very different experience for the patient, despite doing much the same things as we would do in a hospital setting. For time reasons, I'm going to skip the second case, although I might refer to it later on in terms of some of the reflections I've made. But it's just to illustrate how it might feel for the patients in the system. Now, when we teach medical students, we teach them to take a detailed social history, is what we would call it in the UK. Is that familiar language over here? That is around the broader aspects of a patient's life, not just their health needs, but what makes them tick, who they are, what their living circumstances are. And one of the things that I've found in working in a hospital-at-home environment is that it's really opened my eyes to different elements of a patient's life and health experience. This is a patient's fridge. Scotland is famous for alcohol. You'll notice, first of all, that all the beer cans are empty, but the full-fat milk is full and unopened. So you can imagine this man's nutritional state. Just out of interest, this fridge was placed in the man's bedroom at the end of his bed. So you start to form a bigger picture about this man's dietary and social needs and habits. But it's been quite an eye-opener. This man suffers from pigeon fancier's lung. Don't know if you get that much of that over here. The diagnosis was easy once I'd seen the room. But the significant thing for me is this man was once Britain's foremost pigeon racer. I know nothing about pigeon racing, but it's big business. Some of the birds he used to sell would sell for 10, 20 or 30,000 pounds per bird. There's a significant whole other world that I didn't know about. This one room is full of trophies. I couldn't get them all on the photographs. But the rather unassuming sheds in the garden currently house 300 pigeons. Now, every 6 months, this man goes for a hospital appointment to see a hospital physician who sees him for his lung condition, and every 6 months he badgers him about giving up his pigeons, because it's the only way to stop the progress of this disease. Once I'd been in the house, I was about to start the same conversation with the patient when the daughter interrupted me with a cough and brought me into this room. And once I had seen this man's life revolved around pigeons, I abandoned that conversation, because very clearly he's not going to give up his pigeons. So seeing the patient in their context was very striking. I don't know if you have these over here. These are very popular with patients. They're hated by physiotherapists, but a wheeled trolley with a tray that allows you to take dinner to and from rooms. In Scotland, they're much loved by patients because you can accumulate a number of things. For instance, where else can you keep your cigarettes and your inhaler in the one place? Or your biscuits and your diabetic tablets? I'm told you don't have Iron Brew. It is a soft drink with a mixture of caffeine, sugar, and rust. I think that's the best description. It's a uniquely Scottish thing. I shall need to see if we can get some imported. So I've learned a lot from being in a patient's house that being in a hospital and asking questions just doesn't tell me. But I wanted to just talk a little bit about some of the evaluation that we've done of our particular hospital home service and then move on to the research that we want to do. Very briefly, this is our team being filmed for national news. Our health minister got wind of our service and we ended up on national news. And one of the things I have learnt is that you get punished for your successes more than you ever get punished for your failures. It's brought a whole whirlwind of interest and challenge. We wanted to be evaluated on how well we performed in terms of safety and other patient factors such as their satisfaction. But it gets complicated when publicity gets out. But we did do some research to look at, this is really service evaluation, to look at how safe our service was. I was particularly concerned that it should be safe. It should be as safe as hospital, if not better. So we looked at 30-day outcomes 6 months into the study, and we looked at the first 400-odd patients. And we compared the mortality rate for the hospital at home arm with historical data that we had in the hospital. Now, there are challenges when you make comparisons of different cohorts, but I was reassured that at least we seemed to be at least comparable. We also had to look at readmission rates. Remember, I mentioned that there was a concern that there is a theoretical risk of increased readmissions, and that didn't seem to be worse between the two groups. We also then explored the 400 patients. We will choose to admit about 1 in 5, so 75 to 80% of people we will keep at home, but we will choose to admit people who we are concerned about as not being safe to stay at home. And we wanted to compare the outcomes for those we chose to admit and those we chose to keep at home. Now, you might not be surprised that the mortality rate for those that we chose to admit was slightly higher. This was a sicker group of patients, but it's important that the difference is that way round. Readmission rates, again, were not that different, but strikingly, a large number of people who'd been admitted to hospital were still there, which got my manager's head slightly concerned. So as far as we could tell in the first 6 months, we were happy that the safety systems seemed to be okay. But we haven't just looked at that. We've looked at a number of different things. The big blue part of the pie is where our referrals come from, primarily from primary care physicians. We've asked and we've catered the service to take the referrals direct from them. But we're trying to increase the number that come from the emergency department and expand on that. And we will be having our 3rd birthday next week, but this is data taken 29 months into our running, and we've had roughly 100 patients a month recruited to the service. And it's not surprising that the bigger portion of that is older women. Our average length of stay is shorter than hospitals, but there might be multiple reasons for that. And importantly, about 3/4, 76% of the patients we're managing to keep at home in their own home. So that's reassuring. We looked again at mortality rate for 29 months in. I talked about looking at it at 6 months in. And again, we've compared to a hospital cohort. And so far, we seem to be comparable to a hospital cohort for mortality, and that's reassuring. Roughly 1/3 of the department's acute work now is actually taken with patients in the hospital at home arm. So a significant chunk of our emergency work is now through hospital at home rather than just through hospital. And that's very much the direction of travel that we want. We've actually closed 50 beds now, which represents 20% of our specialty beds in this hospital. So we're reassured that we seem to be impacting on the same group of patients. We're not treating a different group of patients. It seems to be the same group of patients. We can only close an empty bed, which our politicians worry about, quite rightly, but we can only close an empty bed, so these are empty beds. So the demand seems to be being turned off slightly. We've done qualitative evaluation, and we've also done a little bit of economic evaluation. We've introduced new systems. This is, I talked about the virtual ward. We can't see the patients, so we had to introduce IT systems that allowed us to know exactly where they were, what their parameters were. And we've hooked up with Google Maps, so although we can't see the lady in bed number 4, we can see the house that Mrs. Jones is in. We can even go into Street View and look at that. And we've also started working with the ambulance service to try and address those who are seen by the ambulance paramedics, not just by their primary care physician, to try and change the tide in terms of avoiding hospital admission. This is one of my favorite graphs. You remember we talked about the 5% per year increase in hospital admissions? This is looking at the rate of increase in hospital admissions since we started and this is looking over a 2-year period. So on the right, for every sector that doesn't have hospital at home, you would see what you might expect to see. 11.7% over 2 years, just under 6% per year increase in hospital admissions. However, in the sector that have our hospital at home service, which is called ASSET, only a 1.3% rise in hospital admissions. So we think we're turning off the tap. We're turning off the tap of demand, which is really important. In terms of costs, difficult to do. We looked at the costs of an acute hospital bed, the costs of a step down, that's a rehabilitation hospital bed, which is slightly cheaper. And then we looked at these virtual beds, and these can be driven by all kinds of factors. If we have a relatively low, if we take 5 patients per day into our ward, what would that cost us? And then we looked at if we were working at maximum capacity at 8 patients per day, and what would that cost us? So the equation for a virtual bed, for the hospital at home bed, is significantly cheaper than a hospital bed, which is good news. And we've done qualitative evaluation. We did some semi-structured interviews with patients. We want to collect their perspective on what it was like to experience hospital at home. And overwhelmingly, the response from patients and their families, and significantly, was very positive to the hospital at home experience. So that was important and reassuring. I may have hinted at this, but I've made some significant changes in my own thinking and my own experience as a clinician. Having moved out of a hospital, it's been quite a learning curve for me. One of the significant things that hospitals don't adequately identify is that there is a family around every patient and every person, and that family might be biological, but even in people who live on their own, there are neighbors, there are nieces, there are friends. There is a network in which people live, and we don't adequately deal with that broader picture of the patient's perspective. And that's been quite an eye-opener for me to have a consultation with the patient and their family there. It's been a very rewarding experience and a very significant one. I've learned to, a lot of physicians like to think of themselves as a Sherlock Holmes. It was based on a Scottish physician. They like to think that they can diagnose something intuitively. I'd love to think of myself as Sherlock Holmes. However, my students prefer to think of me as a Columbo. Apparently, that's what they call me. I don't particularly care. It's quite flattering all the same, but I've learned to diagnose various different things and spot things I wouldn't have spotted before. I could tell you quite a lot about the occupants of this house just from the door. I've learned how to tell if a patient is well cared for by family or others by the state of their garden. Family never quite take the same care around the garden that the individual might themselves. It's quite interesting to observe. And I've learnt as well that the idea of working out what medicines a person is taking, sorry, go back one, is a very, very different ballgame in a patient's house from what it is in a hospital. We get lists from the GP that says what a patient should be on, but open a kitchen drawer or the bags under the bed and you'll find quite a different story. So it's a very significant thing. This was the second case. What the interesting thing around this case is this man whose wife was dying. They'd been married for 40 years. Every morning he set out the breakfast table for them both. The significance of a picture is that they're not at the table because she's dying and he's at the bedside with her. It's quite a new experience. It's not a new experience to talk about difficult things with patients, but it's a very different conversation in their own home. It takes on a different context. It's their forum. It's their, I'm a guest in their territory. It's a very different experience. And for me, it's been a very humanizing experience as a doctor to do that kind of difficult conversation on the patient's own territory and in their own terms. Very briefly, I want to talk a little bit about how we moved from the evidence base at the beginning and how we want to do more research, and finish with that, if I may. I mentioned the problems with the evidence base. One of the main problems for me is that it combines stroke hospital at home care with general medical hospital at home care for older people. And I would have a question as a clinician about whether that's the right thing to combine those two conditions and assume that they're the same. The second conundrum related to that is that stroke hospital at home was safer than general medical care in hospital, but not as safe as stroke unit care. So, in other words, what is the comparison that we're doing? And one of the things, so that's what we would call the control group. One of the things in the research evidence is not clear is, for those who were admitted to hospital, did they get the best standard of hospital-based care? Also, the research base is very small. The numbers are really very small. We're talking about, in some of the outcomes, maybe 600 patients contributing to an evidence base. And for me, that isn't enough of an evidence base, and we need more. That hasn't deterred our health minister, who has argued that in every part of Scotland needs to have a hospital at home team. But I think we need more evidence behind that. So we've been working as a collaboration funded from the National Institute of Health Research in the UK, working with the University of Oxford to recruit 6 hospital at home services across the UK. And we aim to recruit 1,500 patients, just over 1,500 patients, across the course of 2 years with a year's follow-up. And what we want to look at is, does hospital at home, compared with the best standard of hospital care, reduce the risk of death or nursing home admission? Many of our patients have said these are just about as bad as each other in their perspective, so we want to look at them both together. So we need to recruit a huge number of patients. This is a big ask, it's a big trial, and it's going to be challenging. We're going to recruit on a 2-to-1 basis, so we're going to try and recruit 2 patients to the hospital at home wing for every 1 patient we recruit to hospital. We're looking at a proper economic analysis, looking at this in detail, and we want to look at it from a qualitative perspective as well. What is the experience like for patients, and what are the processes of care that we put in place? What makes a difference? I mentioned the control group, that is the comparison group, and we want to look at patients who are frail being treated in specialist geriatric services, which we know to be the gold standard of care for hospital-based care. So we want to make sure that the comparison is fair in that respect. In terms of the trial timescale, I said it was 2 years. Funding was just confirmed in the summer. We have to recruit our first patients by next month, I believe. 2 years after that, we'll be finishing recruitment and we'll have a year's follow-up. So it's a while before a trial of this size can give us more answers, but we hope very much to be able to contribute to that existing evidence base with a message around what really is safe. In the meantime, we expect that many other people will be starting up services like this. And we certainly hope a lot more people will be trying to start trials as well. We need more trials out there to try and contribute to the evidence base, to add to its nuance, to its complexity, and certainly to its size. So finally, if you'll forgive me quoting an American to a Canadian audience, I do like Mark Twain because he has a whole number of one-liners that are so many of them are appropriate to different settings. From the perspective of hospital at home, I certainly believe it's easier to stay out than get out. And I will leave you with just a simple plug for Scotland and its natural beauty, and try and encourage you to come over there. I'm certainly impressed with Canada. This is my first ever visit and I'll be back, but do please try and visit Scotland. So thank you very much for your time and your attention. Thank you.
Thank you very much, Graham. We now have Andrew, who will take a few minutes and give us his thoughts, his remarks from researchers.
So very pleased to be able to attend this evening and to participate. My role, as discussed, I think, is to give you time to think of very important questions that you could ask Graham, and so I'm very pleased to fill that role. It was a wonderful talk, and I'm struck by really how timely it is. As Graham mentioned, we have a demand problem for acute and hospital care, certainly in his context and certainly in the Canadian context, where we have more older adults who are aging and will need that type of care going forward. In addition, we have a reduction of acute care hospital beds compared to the number of older adults that are around and our population in general, where we see less acute care beds per capita today than we had years past. And that problem will go to the future, of course. And in those existing beds, we have delayed discharges and bad situations for individuals where they're in a place where perhaps the level of care is not needed for them, but they have nowhere else to go. And so further challenging the number of acute hospital beds that we have. In addition to that, I think we have a greater demand problem in the future than we have today, where because of constraints in funding, we're probably not going to see new capital funding around new hospital beds going forward. And so, not to put too strong a point on it, I think the issue around hospital at home maybe is less about, well, certainly is about a quality improvement and good patient care, but also about a matter of potentially survival for our healthcare system going forward. And so it's very important to think about, I think, in that context. The talk brings to mind a couple of contentious points, I think, worth mentioning, and something that potentially we could focus on for discussion. One is the assumption that, well, we maybe don't need acute care, or either at home or in the hospital, because we'll probably have innovations where we're going to attenuate the demand for acute care, which is that much of acute care is probably avoidable. And if we had better primary care, community care, we could probably avoid the mess, and that would be our solution. Perhaps we don't have to think about hospital at home. And a bit skeptical at that point. Perhaps you might be or might not be, but so far we have very little evidence that we have very much effect on attenuating the demand for acute care among older adults, where we tried various interventions with either results saying that there's no outcome, no benefit, or that the benefit is marginal. And so it's a tough problem, of course. I think there are probably solutions, but certainly wouldn't solve the issue. When we think of emergency department visits for older adults, we find that it's quite the opposite. They're the most appropriate users of the emergency department, and we find that over and over again compared to other populations. And their rates of emergency department use are, of course, increasing more and more. So it's an important issue. Second is the contentious issue around costs, and that hospital at home should be cheaper, or community care in general should be cheaper, or it ought to be, or it is. And the problem with that logic is that I think the maxim that good care is always cheaper applies, and that poor care is always a false economy. And I wonder if the outcomes were as good or better, and of course there was choice there that the individual would receive care in the home, and the costs were the same, would that not be a positive outcome? If they were more expensive, but the outcomes were the same and choice was there, would we not be satisfied that that investment is worth it for people's lives and for their caregivers? And when we think about cheaper, we would think about cheaper for whom? For the system, for individuals, for families. For whom is it appropriate is important, I think. And obviously there's cases where Graham has found that it is very appropriate. But of course for some older adults with certain conditions, there are obvious economies of scale where if we think of older adults living together in group environments, whatever they may look like, that might be more efficient and more satisfactory for individuals who need that level of care. So questions, I think, for all of us to consider, and I'm not sure we have definitive answers to those. So in my remaining time, I thought I would focus on a readiness assessment, which I warn you is slightly bleak. If we were to pursue hospital at home in a greater way, I think it is important that we would consider it and likely move in that direction. Number one is currently we have an adequate supply of geriatric specialists in Canada, whereas potentially our economic situation is better than Scotland. Our access to good geriatric care is much, much worse than what is available. We have about 240 geriatric specialists in Canada. I mean, think about that, 240, given our aging population and the fact that we'll have more older adults. That's roughly 1 for every 20,000 Canadians over the age of 65. And ask yourself, is that enough? What steps should we need to make to move this forward? Must keep in mind, of course, that these individuals themselves hope to retire. And as much as we try, we probably can't stop them from from leaving their workplaces when they reach an age when they've about had enough. As a result, training in geriatrics is generally poor for all healthcare professions. And of course, we need to meet this shortage very urgently if we're to consider good geriatric care as well as models like hospital at home. Finally, we have poor integration of primary and community care. And this is an issue where primary care physicians don't speak with home care, and vice versa, the situation isn't as good as it might be. So considering an innovation like hospital at home becomes problematic unless we can work out in the community how collaboration should be worked out. Inserting hospital at home would be challenging, where communication between the primary care physician and the hospital at home team and, let's say, home care or community care isn't what it might be. And so, of course, we need to think about solving that issue. Third, we have poor quality design around screening and assessment. Hallmark of good geriatric care is an assessment. Currently, we have problems where healthcare organizations don't share information, and so it becomes very inefficient. And patients do things like they memorize the MMSE or the MOCA test, which gives you, of course, false readings, where you can have in any given hospital stay in one given organization, multiple individuals asking the same questions over and over again to the patient and the family. It's very frustrating for the patient and for the users of that information. So we need to work that out. Finally, payment. Payment is an incentive, and do we reward the kind of work that Graham does the same as we reward individuals who provide care in hospitals or in clinic settings? And if we don't, we probably can't expect the model to thrive. So with that, I think we'll have questions. So a question from Twitter, from Carol Ann Alloway. Did Dr. Ellis survey careers on success of the program? On success of the program.
Yeah, so the semi-structured interviews that we conducted with the University of the West of Scotland, which is based in Hamilton, was of patients and caregivers together. So it was in combination, absolutely. And one of the things that's been striking for me was when we started out, many people said to us, well, the caregivers are going to be the ones who are going to be protesting against this. You're pushing the strain onto them. One of the things that has really overwhelmingly surprised me is how often the caregivers are as supportive of this as the patients themselves are. And often when you've sat in their living room, you've explained what's going on, and they understand that better, and they feel that they are part of the solution, I think they can understand what they can contribute to that. And you've kind of alleviated some of their fears. So it's been a very striking thing for me how often they will choose and volunteer and participate in the support of the patient very willingly.
Fantastic. Also a comment from Carol. Readmission in her experience is because of discharges that occur too early. Do you have a comment on that?
Well, classically there's two types of readmission that are described. One is where the previous discharge was poorly coordinated, perhaps the patient wasn't ready, and they come back into hospital a short time afterwards. We talk about failed discharges. It's a terrible terminology, but these are the short readmissions where clearly things weren't well sorted. But we also recognize that in the frailest population, there is a different kind of readmission that occurs if you look at a longer time period. So if you look at 30 days or 3 months, you often find they're coming into hospital with another condition. So that's not a failure of the previous admission, it's the fact that they are very vulnerable to new problems. So there are two types of readmission. And absolutely, to address the first type, you need to make sure you've done your work well in getting the patient completely better, you've planned their discharge well, you've liaised with community services, and you've done all your homework, or the patient will be back in. And that's a very clear message. But there is another type of readmission as well, which reflects the patient being a very dynamic, frail, vulnerable patient group. So the two dynamics do exist.
What proportion of your cases would you say are from, are as a result of readmissions that would otherwise be prevented with perhaps better discharge planning from the hospital?
Yeah, $1 million question. I think there's a balance to be struck with readmissions as well. So for instance, if you have no readmissions, that doesn't say a lot that's good about your system. That sounds a bit perverse, but if you're not getting any readmissions, you're not taking enough risks in terms of getting the patients home. So you should expect a few readmissions, and in fact, the patients are the ones who are fighting to get out. So there should be a little bit of readmissions. However, if your readmissions are too high, it does point to poor planning. I'm not sure what the perfect number is, and I think certainly we should be always striving to improve the planning for discharge. But we do see a proportion of patients where they've been discharged from the acute hospital and they are subsequently admitted to the hospital at home. I would always prefer to see them in home and avert a crisis than have them go back into the hospital building.
Please, question from the audience.
This is to Graham, and actually Andrew alluded to it. I understand why you want to do a trial against the gold standard of the geriatric care in the hospital. But Andrew suggested that actually for Canada, it might be just as valuable to get the data comparing your service with standard hospital care, because likely most people that come to hospital are not going to get that gold standard of geriatric care. So I think it's important actually, maybe, I know that you'd like to show that your service is up to gold standard, and that's important to do, but the relevance of the standard care that is less homogeneous, much more heterogeneous, unpredictable, is actually very powerful data, beyond Scotland anyway.
I mean, that's an interesting observation, and I suppose that's where Andrew's role comes into this, is when you see the evidence, you have to interpret it for your own context. You have to understand what is the situation we're in and does it apply, or which elements of it apply. I think that's a fair point, and I suppose that depends on the context you're coming from. I suppose I would still argue for the gold standard has got to be done, knowing that there is the alternative in the context in which we work, and that we could admit you to the best, the gold standard, versus the not so good. You know, I couldn't justify that, but you're right, the context determines how you interpret that evidence.
And you would have to decide whether the data that you already have are sufficient for the normal comparison, or put an arm in of that kind of standard care.
Yeah.
Hi. Hi, Graham. We met earlier today. I'm a doctoral student in the School of Nursing at McMaster, and I'm working with Dr. Maureen Markle-Reid, and my research is looking at interprofessional collaboration and education among home care teams in Ontario. So I'm just wondering, Dr. Ellis, if you could speak a little bit about the background of the team members that you've incorporated into your hospital at home program, as well as any training and preparation that you had to provide for them in order to work in your new model.
Okay. That's been another learning experience for me. We have a team that is in part from community. We have former district nurses who've recruited from the nursing element. Some have come from the acute hospital background, working with older people, physiotherapy and occupational therapy, and we have a community psychiatric nurse. They've all brought their own strand and their own experience into it, and that's been interesting. But where we've trained them up is in the physician assistant type skills to replace the junior doctor role. So they started from one context and have become something quite different. And we did warn them that they could never go back, they would never be the same. But the other interesting dynamic is in working together closely, over time, it's become quite important to be a very close-knit team. So if I send out a nurse, I'm not sure who's the boss in the arrangement, but in any case, they're not here, so I can say that. If a nurse goes into a house, I need to understand what is her current experience and what is her knowledge. So when she examines an abdomen, I need to have comfort that her examination skills are up to a certain standard and that I can trust that. Or when she describes a situation of risk or stress, is she describing from, is she the type of person that is comfortable with risk and therefore I should read this signal as something of concern? Or is she someone who highlights a lot of things and I need to interpret that risk? So that becomes the kind of knowledge you only acquire through working in a very close-knit situation for a long period of time. And that's been quite an interesting learning curve for me and for us as a team. So it's a little bit about the cement between the bricks. It's that invisible element that makes a team knit together, understanding each other, knowing each other well. that it's just as important as the knowledge and the skills and also the experience that you bring with you. So all of those elements have been quite a learning curve. I'd quite like actually to take it back into the hospital. That's one of the things I'd quite like to do, is to change the way we do things in hospital, because that whole learning of how teams can work better, and when they work well, they're just, you know, it's quite extraordinary. So I'd quite like to take that back into the hospital.
Mark Kamath from Department of Medicine. I'm an engineer. I'm just wondering if you had to orient the technical infrastructure in the houses that these patients were, for example, whether the internet could be sort of employed to harness its benefits. For example, would the ECG be available online? Number one. Number two, were there a spouse or somebody, alternate person in the house, or did you have a lot of patients who are single, and whether that made a difference in the amount of care that you had to give, number of personnel, and so on and so on. Thank you.
So taking the first question around technology, I've had a number of discussions today, in fact, on that subject. My feeling is if we get our systems right, the technology can help. If we don't get our systems right, the technology can't. But we would quite like to look at the next boundaries we want to push are around giving intravenous treatments in the house. We've acquired oxygen, which we can deliver in the house. But when we started, we had to think about what was safe, first of all, and secondly, what was cost effective. And many of these additional technical solutions have logistics that mean that they are potentially more expensive. So we hadn't started there, but we're keen to go there. In terms of information, we're moving to having iPads, which we take about, which have the patient's information on them, trying to move to having health records, diagnostic information, letters, etc. But it's a slow process because our systems are slow to adapt. So we do hope to get there. In terms of your second question, one of the objections people raised was that many people, it would be fine if the family was supportive, if there was lots of family, this would work. For patients who live on their own, and that's a growing proportion, this clearly won't work. However, that's not been our experience. As I say, we often find that there are very few people who are really completely on their own. It's been very striking how many people have long-term neighbours. I had a patient on Friday whose next-door neighbour was her next of kin, power of attorney, and who was very involved in her care. Friends, slightly wider extended family. But also we're able to put in home care in the sense of home helps who are able to do personal care. And they're able sometimes to supplement for that missing element. When we started, we thought that that would be very expensive and we would be providing a lot of that to make it safe. What has surprised us is how little of that we've actually required. There are some cases where we definitely need it, but it's been far less often than we would have thought, and to a far less degree than we would have thought. And part of that's really getting them over the physiological dynamic of the acute illness. And as they start to get better, they reacquire skills quicker, I think.
Hi, I'm Tom Pierce. I'm from the Community Care Access Center, the home care program here in the region. I wondered if any of your research also looked at the effect of the program on the demand for what we call long-term care homes or nursing homes. You talked about bed closure in the hospital. Have you seen either a delay or a shortened length of stay in nursing homes?
So that's a very important patient outcome. They're very keen not to go into care homes if they can avoid it, by which they mean they want to be independent and in their own home. And we're very keen to look at that. It's a longer term profile. In the trial, we'll be looking at that very specifically. So we will have some answers from that. We have been looking at it from a hospital level because we're keen to see that coming down. We're keen to see fewer people needing long-term care. And the trend in our sector has been for that to reduce, but it's hard to be sure about the impact specifically. So I'm personally very keen to see a shift away from institutional beds towards more independent people, more able-bodied, and certainly more care in the patient's own home.
So another question from Twitter. How do you convince doctors to look beyond their specialty to the patient and their social milieu?
Okay. Yeah. Well, for us in the UK, there's a number of different things that are happening all at once. I did talk about the challenge from this one particular hospital system that had failed badly. It's raised questions about our care. So there's some debate both in the public press and in the hospital press around the element of how do we write our core values into our healthcare systems. So that's been quite a positive discussion, and I think for some doctors that's led to a degree of soul searching. In Scotland, there's been a focus on older people having a closer say in their healthcare. They talk about changing the nature of the question we ask our patients towards what matters to you and away from what's the matter with you, if you like, which may seem a small wording change, but is a whole different conversation. So we're trying to stimulate that debate nationally. And we also talk about 5 things that you must do with me rather than do to me. We're trying to change the context of the conversation nationally. But we've had tremendous kind of change in our perspective. Certainly I've noticed that in my own case through being in a patient's setting, in a patient's house, in conversation with the patient's family. So I would love to have more people have experience of care in the community, care in a homely setting, or care in hospital at home. And we've had a number of trainees in my specialty who've been able to spend a period of time attached to our program. And I think they've been able to observe how different the conversation is when it's conducted in the patient's own house. So I think it has to be tackled from a number of different perspectives. But certainly leaving the hospital building helps a lot.
And if I may, with that added perspective that you mentioned, so we have the challenge of siloed care, hospital care, primary care, and then community social care. With your added perspective, do you find that you're able to, and some of the outcomes speak for themselves, after you discharge from your service, coordinate care with primary care and community social care better than you would otherwise in the hospital?
Yes, we had partnership from our social work colleagues. In hospital systems at the moment, where we are, we have to wait 5 days for home care to be available, so that leads to delays. With this service, we argued that we would have to have immediate same-day home care because it wouldn't be sustainable for some patients. And so that has led to a really positive experience of partnership between social work and our healthcare teams. And I think that they've learned to trust our assessments of the situation, and the fact that we haven't required that in excess of what might be expected has been a positive experience for them. In terms of relationships with primary care partners, we've found that, for me, many of the primary care colleagues that I knew before, I knew them as names on referral letters and on letters I was writing to them. Whereas being able to go around practices, meet with them, know what they look like, what they sound like on the telephone, and that they're willing to phone up for advice is a very different experience. We haven't yet done this, but I'd love to survey the primary care colleagues for their experience of the team, but many of them have been extremely positive. And I think for them it's the access to advice, it's the access to an alternative to hospital, and it's the access to specialists that has meant it's a different relationship to how things were before. So changing the way we deliver things has changed the whole dynamic of relationship in a positive way.
Great. A comment from Twitter. Essentially, this individual is not so much concerned about hospital home, but around helping older adults live well and participate in the community. And so I assume you find that through your program, that's achieved. Can you comment on that?
Yeah, so the ambition that we all have, and it's in your portal film and in the ambitions that you're trying to achieve, is moving the debate away from hospitals, away from institutions, to active, independent, healthy lifestyles for older people. And we're starting to see shifts in that, but we very much want to start to change the paradigm away from looking at sickness and looking at expensive health care. In our program, we're dealing with the very frailest older people, and so it would be hard to see that all of them are able to participate in life as they might have done 5 or 10 years earlier. But what I think we'd be pleased to be able to see, and we definitely are able to see this, is that patients are more able to continue being part of their family, continue being in their own setting. Sometimes that means continuing being able to do certain hobbies, and for some of them it means staying out of institutions that mean that they regain and retain their freedoms. But we're talking about, for my specialty, the very frailest end of the spectrum. But I suppose it's part of that bigger picture that we should in healthcare be moving the debate for older people away from sickness and from healthcare towards independent living. So I suppose we contribute a small part to that whole debate. But for individual stories, it's really rewarding to see individuals who can feel that they've had that benefit. Yeah.
Yeah, I mean, you mentioned the gentleman with the pigeons. I'm sure that made a very big difference in his life. Wasn't another person sort of recommending that he drop that hobby? A very pointed question from Annette McKinnon. Annette might be a health system planner, I don't know. Across the board, what % of beds were you able to close?
Okay, so for my specialty in geriatric medicine, we closed 20% for that sector. And in terms of the proportion of total hospital beds, that amounts to about 10% for that hospital sector. So what we would really like to do is expand the hospital at home program so that we were able to take, I said we were taking 30%, I'd quite like to push that to 60%. Our health board is ambitious to close another 50 beds. And certainly I'm keen to do that if we can provide better, safer, and from an experiential point of view, more satisfactory alternatives. So I think we want to be fairly ambitious in terms of trying to shift away from institutional beds.
As an extension, what result does that have on the hospital itself and those who are working with the hospital? Is it a shift then to the community?
So, I mean, you rightly pointed out that we're not necessarily preventing hospital admission in what we are doing. We are an alternative type of hospital admission, but we're trying to shift it away from the institution, the building at the end of the road, to that hospital coming to you. So we are trying to shift services. What we need to do is to address that whole prevention so that patients don't necessarily need to be admitted to either my service or the hospital. But that's the area where, as you highlighted, we still need more evidence around what keeps people well, what keeps them out of hospital. So we've shifted some resource to hospital teams in the community, and some of that resource that's been freed up by hospital bed closures has been moved to district nursing services, to social work services, and to alternatives. So there has been a real shift from institutional beds to community services in real terms.
Great. Any other questions? Oh, great.
As a nurse practitioner here in our community that's hospital-based, a lot of our patients we see that come into emergency often have pre-existing cognitive impairment, such as Alzheimer's disease, vascular dementia, with an acute illness. And I'm interested to know if any of your patients in the home setting had cognitive impairment, were perhaps living alone, but became then therefore more delirious as a result of their acute illness. And were those the types of patients then that you said, this is not manageable by the team?
Yes, fantastic question. So a significant proportion of the older patients that we would see both in hospital and in the hospital home service have dementia, and a significant proportion of them, I think I said it was maybe about 15%, will also have delirium. It's slightly higher than that. One of the things that's interesting for me about hospital at home is, could it positively impact on delirium, either by prevention or by shorter or less acute illness? And anecdotally, what we see is that patients with delirium in the home setting, they still have delirium, tend to, and this is anecdotal, tend to have a shorter duration of illness or a less severe duration of illness. And one of the reasons I think for that is that the environment in which they are placed remains familiar. So although the acute illness has maybe caused the delirium, and that may cause agitation, hallucinations, behavioral problems, it seems less severe than in some of the patients who are admitted to hospital. So for me, it's one of the strong arguments for hospital at home because you're not adding into that delirium picture a translocation from a familiar setting to an unfamiliar one. Someone did a study of the first 3 days of hospital experience, and this must have been a UK study, estimated you might see 120 completely new faces in a hospital in 3 days. In your own home setting, you would probably see a few new faces from our team coming in, but nowhere near that degree of new people. It's bewildering in hospital, so we hope that that would be positive.
Hi, I'm Padma Kamath. I'm not in the medical field, but I have been doing some research last 2-3 months on in-home non-medical care as well as in-home medical assistance. This is mostly US. And most of the time with the in-home non-medical as well as the medical care, the network of these service providers, they have registered nurses and also, I guess, access to doctors. How easily could something like this be expanded to do the hospital at home, care?
Yeah, so it's another interesting question. And it's a debate where I work currently, which is, could primary care address some of these needs? And primary care in its broadest sense, I beg your pardon, that may be a Scottish context description for a wide range of services, not just the GP or even the district nurse. Could a team of people do that? What we're very keen is to expand the capacity of the team in the community so that they can manage more. And that might include a small proportion of people who would otherwise have ended up in hospital. And certainly the teams who work in the community feel very ambitious and optimistic that they would manage some of that. So there's no good reason not to do that. There's no good reason not to enhance and enable that team to handle more. I think the element where I guess I would come in is where that team feel that they no longer feel it's safe to do so. And that I come in as a hospital specialist. So, conditions like pneumonia or some exacerbations of chronic obstructive pulmonary disease or multiple organ problems, delirium, etc., might be the element at which the teams in the community teams might not feel it's safe any longer. And I would normally, one of the reasons we designed this around referrals from the primary care physician was we did not want to do their work. We did not want to step on their toes. If they're able to do this, then we would be very happy. But there's no shortage of work out there. So where we would come in is when they would invite us in, or where they would normally need a hospital to do what they couldn't do. So I'm all for enhancing that community basis.
Great. Thanks, everyone, for your questions. Those online and those here. Thanks, Andrew, for helping to facilitate the Q&A question and for your earlier comments. And thanks very much, Graham, for being with us tonight and sharing your thoughts and your insights and your work. We wish you continued success. And now I'll just mention the 2 events we have coming up on December 8th and December 9th. They will happen here at the McMaster Innovation Park at 7 o'clock on both days, and we'll have them web streamed as well. On the 8th, we have Janice Keefe, who holds the Canada Research Chair in Aging and Caregiving Policy. She will tell us from her extensive work focused on the critical role that unpaid caregivers play. We'll share insights on the health, financial, and employment impacts for this population. And she'll talk to us about what can be done better to support them. The following evening, on December 9th, we have Richard Schultz, a professor from the University of Pittsburgh in USA, and a leader in research on the health effects of caregiving. He will talk specifically about challenges faced by caregivers of those with Alzheimer's disease. So we hope to see you there. We hope to see you online. Thank you very much again. Thanks to our wonderful planning team. And good night, everyone.